Good evening, good afternoon, depending on where you are. I'd like to welcome you all to ASTRO's Diversity, Equity, and Inclusion in Radiation Oncology, that's DEIinRO, Social Education Series. I'm Dr. Gita, Suneja, and I'll be your host for this session on social determinants of health, understanding barriers to overcome obstacles. This new social education series is brought to you by the newly formed ASTRO Ex Officio Council on Health Equity, Diversity, and Inclusion, CHEDI, the Committee on Health Equity, Diversity, and Inclusion, and the ASTRO Division of Education. This series focuses on conversations with our members, learners, and patient communities. You'll also hear from leaders in other specialties and industries on several topics related to DEI and belonging. The DEIinRO program is designed for us to share our experiences, research, ask questions, and openly discuss fundamental, core, conceptual, and structural issues within medicine and radiation oncology. We know that understanding starts with open dialogue, and you're encouraged to share your experiences and questions with us both during and after the session. You're able to do that by chatting in the fields below or tweeting using the hashtag DEIinRO. Let's take a moment for our panelists to introduce themselves. So we'll start with Ashleigh Guadanolo.
Hi, I'm Ashleigh Guadanolo. I am a professor of radiation oncology and health services research at the University of Texas MD Anderson Cancer Center. I'm also the section chief of the melanoma sarcoma radiation oncology section. I've been there for about 15 years, and I'm thrilled to be here. Thank you for having me.
Okay, and we'll go to Monica Lypson.
Hi, I'm grateful to be here today. I'm Monica Lypson. I'm at the Columbia University Fagelos College of Medicine. I'm a professor of medicine there and the vice dean for education, as well as the president of the Society of General Internal Medicine. So I'm grateful to be here with colleagues.
Okay, Samilia Obeng-Gyasi.
Hello, so my name is Samilia Obeng-Gyasi, and I am a breast surgical oncologist at The Ohio State University, and also thank you for this opportunity.
Great. And as I said, I'm Gita Suneja. I'm a radiation oncologist at the University of Utah Huntsman Cancer Institute and a health equity researcher. Before we begin the panel, we would like to acknowledge that ASTRO recently released a statement on culture of respect on addressing professionals by their formal title at the annual meeting. We applaud ASTRO for this effort and want to clarify that our team and panel members reviewed and discussed this document, and we've all agreed to refer to each other on a first name basis for this session. So with that, let's jump right in. We will start by defining social determinants of health. So the Healthy People 2030 campaign defines it as the conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health functioning and quality of life outcomes and risks. So could each of the panelists please contextualize this definition for us by sharing what social determinants of health mean to you and in your field of study? We can start with, we'll start with Ashleigh.
Thanks. So for me personally, this goes back to when I was in medical school in residency, when my grandmother was diagnosed with lung cancer, and she basically experienced an upstage event due to difficulties with social determinants. She was located close to an Indian healthcare facility, Indian Health Service facility, which was not associated with her tribe, partially because historically, in Oklahoma, under the Dawes Act, many people who received Indian allotment, it was far away from their tribe, and so she was remote from her tribe. And when she needed specialty care, it was very difficult to understand how to get it. She ended up actually succumbing to complications from the lung cancer surgery, likely because she needed a pneumonectomy rather than a lobectomy. So at that time, I spent a lot of time thinking about how things other than healthcare provision conspire to make it difficult for people to have good, healthy outcomes. In fact, if you look at the data, 10 to 20% of health outcomes the variation in health outcomes is actually related to medical care. About 30% is genetics, and the rest is really social and environmental factors. And so as a researcher, I did my fellowship with Dr. Dan Peterite at the Walking Forward program there in Rapid City, South Dakota, where we specifically explored many factors, cultural factors, mistrust, and health literacy and understanding of cancer, basically the narrative around health. He has been in practice there for 20 years with his program, and so that was really social determinants really were a big part of that project. So for me, it's important to understand racial and socioeconomic variation in healthcare as being not just about the healthcare provision, but around the social, environmental, and other factors that bring a patient to a healthcare scenario.
Thank you, Ashleigh. Let's go to Monica next.
So thank you, Ashleigh, for sharing that story about your grandmother, because I think it provides the context that many of us come to healthcare with. Often it is our background, and for me, it is the same way, bringing my background into the space of becoming a healthcare professional and thinking about family members who had insurance, family members who were on Medicaid versus family members who were uninsured or actually also accessing their healthcare through the VA healthcare system. I could see, even as a child, those differences across platforms. And then for me, as a clinician educator, kind of born and bred and trained as a health services researcher, I brought that to the educational work that I did. So had always thought about bringing the patient into the room, bringing the patient, the full patient, into the educational space, and how could we actually adequately teach our medical students and other health professional students about anything in healthcare without talking about the social context. So when I first started teaching, social determinants was not the term, but it was more about making sure patients had a full social history. And sort of by the turn of the century, as we sort of moved on, using those terms coined quite frankly, in the UK, but in the national health system, having social determinants as a framework to think about the full patient experience, the experience that a patient has before they get to you is really critical. So that's something I hope to bring to all of my educational roles. But I do think it is fundamental to think about what context are your patients coming to you in the door with, and what are their lived experiences. And I think if we think about that, we'll find out that they live by a Superfund site, or that they are experiencing food insecurity.
Yeah, thank you. I think it's such a great point that we think of these things sometimes in social history, which is a really small part of the overall history and physical that we do and the information we gather. And yet it's so critical to really ensuring that patients are taken care of and that their cancers are addressed. So Samilia, we'll go to you for this question as well.
So for me, the idea of social determinants of health really came into play when I did a post-baccalaureate research program at the NIH called the NIH Academy. It was a program where we spent time either mostly in a basic science lab. I was at the National Cancer Institute. And then once a week, we had lectures on health disparities. And at that time, I had never heard of health disparities. And I didn't really have a framework or an idea that, there are differences in outcomes based on where someone lives, where someone comes from, what access to resource someone has, nor did I realize it was actually a field of study. So that was the first time that I actually was provided with the language and the framework. And that actually stayed with me all through medical school and all through residency and fellowship. And so when I think of social determinants of health, I think of them broadly as living and working conditions. And as a breast oncologist, that affects my patients from, the etiology of breast cancer all the way through the survivorship phase. Every single aspect of the cancer continuum is affected by where people live, how people identify, and also by their access to and the quality of healthcare they receive. So I think it's hard for me, based on my experience as a post-baccalaureate fellow, to not view medicine as through the lenses of social determinants of health.
Yeah, absolutely. So we'll go to the next question, and maybe I'll direct this one to Monica first, and Samilia and Ashleigh, feel free to jump in. So how do we as individuals, healthcare providers, health systems perpetuate the health inequities that we study?
It is in the fabric of how we talk in medical education, right? We think that we're doing the right thing often by portraying case-based medicine in a 2D format, often PowerPoint, and giving descriptors to patients: African American woman, Latinx man, and what we might actually be doing is perpetuating stereotypes, reinforcing cognitive biases and shortcuts that we really don't need in the diagnostic armamentarium that we're trying to train. So in the educational context, we need to be extremely careful about why, when, and how race is even discussed, because I think we often use it as a term that, despite us cognitively knowing that that is a social construct, it often comes out our mouth as a biologic reality. And the issue is making a clear distinction that biology is not part of the social construct. So even the concept of race, I think, is important. And then if you think about it, I'm a primary care doctor, so I'm excited to be here with my colleagues, how we construct healthcare access. You know, who has access to you all in my patient panel is often a barrier, right? The well-insured, I know who to send them to and how to get them in quite quickly. Those who have underinsurance or no insurance at all, it becomes even difficult. And we know that patients are predominantly, who are underinsured and uninsured, are people of color, indigenous people, and those at the margins. So I think it's really important for us to even think about it in the language we use.
And to piggyback off what Monica just said, I think another issue is actually acknowledging that they exist. One of the issues we have in healthcare is that we don't really acknowledge that inequities are structural and systemic, and they're actually part and parcel of the healthcare that we deliver. And so by not acknowledging it in the first place, we don't really have an opportunity to discuss it. And more importantly, we don't give ourselves the opportunity to investigate it so we can try to come up with strategies to mitigate it. So I would say one of the biggest barriers is having, those of us in the medical field as a group actually acknowledge that, we have a system that has significant flaws, and the quality and access to care is not equitable, and also for all our patients.
So kind of dovetailing off that a little bit, I actually have been thinking about this a lot. And in the run up to this call, we talked briefly about this. So the Commonwealth Fund issued a report actually last week about the state of healthcare coverage in this country, and that showed that the pandemic affected Black and Hispanic and people of color, and they were harder hit in terms of income loss and ability to pay for healthcare. So 38% of insured patients were having difficulty paying medical bills, and half of uninsured patients were having difficulty paying medical bills in a survey of over 5,000 individuals. And these problems were more frequently reported in people of color. And what the survey showed is that this medical bill difficulty was actually damaging credit scores, undermining food security, undermining housing security, interfering with education, and interfering with education and jobs. So, when you think about that, if you think about the history of this country, the great booms, the great economic booms, cotton, tobacco, westward expansion, and the railroads, all of these big booms and expansions have really been on the backs of people of color, and they have involved the disenfranchisement and suffering of Black, red, and brown people. And what it made me think now is that what the pandemic has kind of shown, or pulled back the curtain, is that in this economic era, the healthcare sector is 18% of GDP. And we, health as we have medicalized it, perpetuate and actually accepts as a consequence of that prosperity the impoverishment and disproportionate suffering of people of color, people on the margins, and people who are socioeconomically vulnerable. It's baked in.
Yeah, absolutely. And, I think people think a lot more about treatment disparities, cancer treatment disparities in outcomes. There's a literature on that. It kind of makes the high impact journals where they see these differences. But I'm not sure there's as much of an appreciation for the development of disease and what these chronic stressors do to the body that leads to inequities and even developing these diseases in the first place. Samilia, can you talk a little bit about that and your research area around that?
So I think a lot of times, as you just mentioned, when we think of social determinants of health, we think of, where people live, we think of people's working conditions, but we don't think about the implications of that on their physiology and also at the molecular level. And so concepts such as allostatic load, which look at how chronic stress affects your physiology. So a way to think about that is that if you are exposed to a very stressful situation, typically your body has an acute response to deal with a stressor. Once the stressor is completed or done, your body returns to baseline. But if you are in a situation where you are chronically stressed out, then your body sort of resets itself to address this stressful situation. As you can imagine, that can have significant implications for your health. So individuals who live in situations where they face sociocultural norms that are highly stressful, or people in work conditions that are very stressful, or individuals who don't have the resources to really manage their lives in ways that they would want to, consequently can have significant physiological changes that can have implications for their health. And what we're discovering is that it's not just at the physiologic level, but also at the molecular level. And that's where ideas about social genomics and epigenomics come in, where you can actually have changes to your DNA or how your DNA is read, which can also have implications for your health outcomes, and also can have implications for your clinical outcomes, meaning how you respond to treatments that you receive. So I think what we're discovering is that social determinants of health affect you at multiple levels. And in order to improve outcomes between groups, that we need to think of it sort of at a much more granular level beyond just comparing, socioeconomic status between two groups or race, ethnicity between two groups, and try to understand, okay, how do the environments that people live in, how does it affect them in terms of accessing care? How does it affect their decisions? But also, how does it affect their body, their physiology, and their cells?
Yeah. And what do you think the role is in terms of generational trauma that's passed down and a legacy of these social determinants that carry through multiple families, generations? Do you see that that's compounded? Is it something that can be addressed, looking back?
So what happens is that due to social engineering or maneuvering, certain populations face significant negative sociocultural norms. And so this can happen, for example, if you look at the Black community, Black women in this country, they have high maternal and infant mortality rates. West African women, or actually African women who come to the United States, have similar infant and maternal mortality rates to white women. So it's not about Blackness, right? It's about the society within which they live that is having an adverse outcome for them and their babies. And so it's important to understand that, persistent negative or racist policies can have implications not just to that person, but across multiple generations. And so it's going to take a significant amount of work and effort to actually mitigate, reduce, and eliminate those disparities.
That brings up a related question that I'm going to direct to Monica. So we see often that mainstream biomedical research will co-opt health equity research terms or methods without addressing some of these underlying structural issues. So for example, using race as an analytic covariate without acknowledging that racism is the real risk factor underlying that. So as social determinants of health become, the awareness of them becomes more mainstream, more recognized, how can we avoid this performative misappropriation of the term social determinants of health and also the associated research and interventions?
I think the answer actually was in the prior question, which was really what are the system changes that need to be in place to sort of make sure that healthcare doesn't perpetrate the same discriminatory behavior that it has in the past. And so I think one of the key things is to not just describe, we're really good in the literature of description, is really thinking about from an editor's point of view, from a reviewer's point of view, what is the intervention, and did that intervention actually try to address the structural issues that Samilia had talked about? I think each of us individually actually can have a piece in that as we review papers, as we get on editorial boards, as we think about the literature that we all consume. That is part and parcel of the one fix. The other thing is we need our grant funders and our peer reviewers on that side to sort of to ask the next deep question, right? It's not good enough to do one more descriptive study. In fact, it might be just as harmful, is to actually go in and say, what are you doing to intervene now that we know we've got 30 years of description, almost 50 years now, starting at the Eckinger report in 1980, 50 years of description on these disparities, and now we need to move into how to intervene on them. And I think Ashleigh and Samilia have articulated, we need to know more. I mean, that's the exciting thing of the science, right? Like the question and bringing diverse people in the room to ask that question about how to do the amelioration piece.
Great. So, Ashleigh, I think the program Walking Forward that you mentioned at the beginning is a really great example of this intervention, amelioration, mitigation. And so I'm wondering if you could share with us some of how you actually implemented that and maybe some of the barriers you came across and had to work through.
Sure. So the program started in 2003, and so 2002, 2003. So it's been in existence for almost 20 years. And I met Dan when I was a fellow at the school, the Harvard School of Public Health. I did a research fellowship. And he at the time was in the early phase. So what we know about interventions that work on a local level. So I think in terms of solutions, there's the sort of local level and there's kind of some big picture. So we'll talk about the local level, which is really Dan's work, is doing deep, good work at the local level. There are really three characteristics, I think, that are kind of key that I've observed in my research. And one is that they're community-based. So they engage the community in a meaningful way. Almost all programs, and at the time that I joined Dan's work, he was really kind of in this phase where he was doing a development period where he was really working with the community to elicit their needs, what their barriers were, what their cultural concerns were, what their explanatory models of cancer and health in general were. And so we did a series of surveys that, and when I was there, specifically explored knowledge and beliefs about cancer and medical mistrust and satisfaction with healthcare. And, you know, when we did this, we engaged the community at every step. And then the third thing that a lot of these programs use are patient navigators, are community-based health workers. And the key, you know, there's a lot of controversy around patient navigation and its efficacy as an adjunct to care provision. But I think the key is that individuals have agency both within the community and within the healthcare system to coordinate care and services. And so I think that would be what I would say about why that program works. And, you know, he has grown that program and it crosses the cancer care spectrum. And so I think if you haven't had a chance to listen to him talk, he often speaks at ASTRO. It's worth taking a listen.
Great. So that's a really good segue into the next question, which I'll open up to all three of you. So in your own careers and research trajectories, where have you seen clinical care on the individual patient physician level, research, advocacy, and policy intersect? And as a correlate to that, how can we kind of leverage or synergize all these domains in our efforts to address social determinants of health?
So I think I don't want to say it's a good thing that came out of COVID, is that a lot of healthcare providers, because the disparities in who was getting COVID and outcomes from COVID was in everybody's face, you could not miss it. Every time you turn on the television, there's a little bar on the side saying how many people have gotten COVID, how many people have died. There are pictures of the types of people who are getting COVID. A lot of people in the healthcare field, I've noticed, have become very vocal about speaking about inequities in healthcare and differences in clinical outcomes. So I think one of the good side effects of COVID is that we now have more people who are healthcare providers who are taking ownership of the inequities that we have in our system and who are willing to discuss this publicly and advocate for their patients in ways that I have not seen essentially since I started medical school. So that's kind of one way that I think things have shifted and are moving in a different direction.
A place to pick up where I think across all specialties have really sort of gotten that advocacy voice that Samilia points out is really around the pipeline. So who actually gets to be a healthcare professional is really one of those social determinants is education. There are educational determinants as well. And I think many of us at our societal levels and at our school levels and our practice levels have said it is only us that can change the look of who gets access to this career. And we all have to have hands on deck to sort of say, we're going to reach back as far as possible to really make sure that people see the roles that we have as potential career option, right? You can't be what you can't see. And it's really key for us to really activate. And I think that activation has happened around the students. So the pre-meds and the medical students have activated around the pipeline. Our societies have activated around the pipeline. The NIH has activated around the pipeline. HRSA, the Human Resource Administration, has activated around the pipeline. I think that is one place where we actually can see that we need to be involved at K through 12. We need to be activated about those early science majors who get disenfranchised about a career in the healthcare professionals. I want to see more radiation oncologists that look like me, right? Like that is important to me, even as a primary care doc.
I do think that's so important. The diversity initiatives, I do think that those are, hitting all of the radars are very important. I think I recently read something that showed that that fewer Black men matriculated in medical school in 2014 than they did in the late 70s. And that number hovered right around 3.5%, which when you figure that African Americans are Black, the Black population is 12% of the US population, we're so far behind. And I think that if you look at similar numbers for Latinx and Hispanic communities and Indigenous communities as well. So that's such an important piece. I agree that that's an important nexus for policy and implementation.
Yeah, absolutely. And we had the last session that we had in this series was on recruitment and retention in radiation oncology. And Monica, I think you're absolutely right that we need to embrace strategies starting very early on from who's in the pipeline and also to how are we supporting, promoting, advancing the faculty that we do have that are from more diverse backgrounds. So that's a really great point and really well taken. Samilia, you brought up COVID, and I think that we would be remiss not to talk a little bit about how this did expose existing inequity, but it also further exacerbated a lot of the inequities that were there. What do you all think the impacts of that will be longer term on cancer care? Certainly, we're already starting to see publications looking at advanced stage of presentation from delayed presentation, and how can we start to mitigate those changes as they come?
So here I have to get patients to you, right? Like, right. And I think the trust question has really convoluted. It has worsened under COVID instead of gotten better, right? It was the one opportunity where the healthcare field could have stepped up and really said, we're going to be different. And I think in terms of, you need that screening test, you need that screening colonoscopy, you need that screening mammogram, from my perspective, is a harder sell in many ways than it was pre-pandemic. And then Ashleigh brought up all the payment issues as well. So, it even starts before people even get to your door.
I think, getting people to come to screening when they're struggling to pay, for food and housing, and to keep their jobs, and to keep their, their insurance, and to, if they don't have safe places to play and work and live. I think that how to put a screening test in the context of your life when you kind of live in this constant existential threat, right? The risk reward calculus of making the time, and time is a big component, right? So if you look at the data, Blacks and Hispanics and people of color wait longer when they go to the doctor. And it's like the number is, it's like 25 to 30% longer than white patients. And so the people who have least agency in their job, and who are least able to advocate for time off and least able to afford the extra hours off work, have to spend more time waiting in the doctor's office to get the care they need. And so if someone's living on the margin, the potential loss of that income or whatever that they have to give up to get to screening for a perceived potential reward, it doesn't really fit into the context of everyone's lives well. And I think COVID has only worsened all of that. And so our challenge is really going to be, how do we bridge back? And I do think trust is a huge component of it. Unfortunately, in my research, not just in people of color, it turns out that actually we've started to see higher levels of medical mistrust among white, college-educated, higher-income individuals, and that's a different podcast probably about social media and misinformation. But I mean that across the board, because used to, when you went to the doctor, several decades ago, you called and got a person on the phone, and it was a doctor that you knew. And most people do trust actually their individual doctor. What they don't trust is institutions and organizations. And now what you get when you try to access healthcare is this big bureaucracy. And this big organization, and I think that's making it difficult for everyone.
So I don't think we're going to know the true impact of COVID for a couple of years. And the reason of that is because as a medical, at least for those of us who do breast oncology, we made some decisions in terms of who we're going to deliver care to during the pandemic due to restrictions on, PPE, and also to make sure that patients who had what we defined as the more aggressive cancers get treatment first. And what we at the time could not take into consideration is that there are certain subsets of patients, like both of my colleagues have discussed, that have faced barriers in accessing healthcare all the time, regardless of how aggressive their cancer might be. And so I think some of those decisions that we made, although at that time appropriate, we're not really going to know the implications of those decisions for certain populations for a while. And so I think the ways that we can mitigate or address that is that we have to start, collecting social determinants of health routinely in our electronic medical records, and routinely try to keep track of this information so we can have a better understanding of how the decisions that we made during COVID, how that's impacted our patients, and more importantly, for populations of people who have faced significant barriers, like Ashleigh mentioned, delays in time to surgery, delays in time to treatment, delays in accessing high quality care, how they were affected by some of the decisions that, once again, though appropriate, added on an additional layer of difficulty for them during a time that everybody was facing significant difficulties. So I'm not sure we're going to know what COVID has done to us for a while.
Absolutely. Yeah. And the idea of actually collecting these in a meaningful, prospective fashion, using the tools we have. I mean, we have electronic medical records that are more than capable of helping to collect this information, prompt providers to have this conversation is really important. I want to change gears for a second and talk a little bit about your careers as health equity researchers and advocates. There are many in the audience who are starting on this journey. They're interested in pursuing this work. And all of us really have found a home in the academic medical environment, but there's certainly other pathways to doing that. Part of the challenge of academia is that there's a currency that people think of for promotion, publications, grants, things like that. And often advocacy work, community engagement, community-based research is not as well recognized. So I'm asking if you can comment a little bit on kind of your own journey and maybe some tips or advice that you'd share with members of the audience who are just starting on this path or interested in moving into this research area.
So I've spent a lot of time sort of thinking about this and advocating for it on the inside. So some of this is understand what the criteria are at your institution. And the reason is because sometimes committees are not following what the criteria is at your institutions, right? People are making decisions. And so one way to advocate for yourself is to understand the rules, because often the rules actually provide a pathway forward, and that it's just not the other people's interpretation of the rules. So that's the way I had to do it. You know, this is now 25 years into sort of doing that, is understanding what the rule is and saying, I actually meet all of these criteria. It just happens to be in this realm that you don't sort of have a full understanding of. So that is one way. I would say it's not necessarily the best way because it is some conformity. The other way is for us to really advocate at the promotion level about what is scholarship. I'm an educator, and the full breadth of scholarship actually does incorporate all of the things that we've been talking about. If you, again, look at the academic definition of scholarly work, and we need to make sure that our promotion committees are aware of that. Sometimes it's actually going back and teaching, reteaching committees about rules that are either on the books or actually advocating for new rules, especially when we are situated often in healthcare in larger campus complexes that sometimes don't even understand the dynamics of what it's like to be a medical school faculty member.
So I think, I would say, it's a little different for everyone depending on the center that you're in. I'm not sure that there's kind of a programmatic one size fits all. And I think, I was really passionate and driven around this work. And even though, 20 years ago or almost 20 years ago now, when I started out, it actually wasn't a big thing in RADONC. When I interviewed for jobs, a couple of individuals who are terrific, and I still have good, they were basically like, I'm not really sure what we would do with that. They just told me flat out, they're like, that's great. We don't know where that fits. Do you want to do bench research? And I was like, I really don't. It wasn't, it just wasn't a RADONC thing almost 20 years ago. But what I found was key champions who, kind of allowed me to kind of plant my roots and grow. And now what that meant for me, I think it was Anthony D'Amico who said, if you want to be successful in academics, you need to write. And he was very right about that. You have to write, you have to work. I think, the finding champions who will listen to you and say, okay, we're going to give you a space for this. I think maintaining a good network, both within and outside of your institution, is very important, because the community, I think, of people who do this, they're spread out, right? Because it's a sliver of a lot of these big centers. It's not, because healthcare incentives don't support it. It's not the key mission of most centers. It is of safety net hospitals in many cases and of public health schools. So I think just understanding the lay of the land, and understanding that, you may, you and I are radiation oncologists, Samilia, you're a surgeon, and we have to do clinical care as well, and how all that fits together, it requires a fair bit of multitasking, because sitting around and writing about social determinants doesn't always fit in with a long OR day or a day full of simulations and weekly Cs, right? So you have to learn to compartmentalize. So I think that, it's different for everyone, and I think you kind of have to understand where you are, but make connections and grow your network.
So I'm 5 years out of fellowship, and so things are still a little fresh. And I would say that in terms of finding success, the two key things are mentorship and sponsorship. I can't emphasize that enough, especially for those of us who are, I guess I'm heading into mid-career, but who are early career investigators, is finding somebody who has some expertise in what you want to do is helpful, just because if you don't, you'll spend a lot of time on projects that are not going to go anywhere, and you're not going to get that time back. And then also and the mentors don't have to be within, like Ashleigh said, they don't have to be within your particular field. One of my main mentors right now is Dr. Ruth Carlos, and she is a radiologist at the University of Michigan. She's not even in Ohio State. So you have to build a strong network, like Ashleigh mentioned, and really be open to people who are not within your field serving as your mentors. And then the second thing is sponsorship. I can't emphasize that enough. It's really important to have people who are going to advocate for you at the table. At a lot of these institutions, a lot of decisions are made by very powerful people. And if you don't have somebody who is going to think of you or bring up your name or advocate for you, it's hard really to move ahead. You can have a lot of wonderful ideas and have a lot of drive, but if you don't have people who are actively supporting you, you will just tread water and not really move forward. So mentorship and sponsorship, I think, are really two key pillars in terms of being able to work in this space and being able to be successful in this space.
And just to amplify that a little bit more, a sponsor is somebody who's going to talk about you good things when you're not in the room. That's the key of sponsorship, that they have skin in the game when they say, hey, I know this person named Ashleigh. I think you need to put her on your committee, or I think you need to do that. Ashleigh is nowhere to be found in that conversation. That's a sponsorship, because I think sometimes those of us in this work get confused between mentorship and sponsorship. And that can be a sore rub, because if the mentor's not willing to put some skin in the game for you, it's not a sponsor.
I love that. I second everything you guys say. I'm over here snapping my fingers, because I think, like Ashleigh, some of the research areas I was interested in, there weren't mentors who were already doing that within radiation oncology. But I was able to find people who were successful in academia who supported my interest. And they said, here are the tools. You can take these tools and apply them to your area of interest. And then as I got more involved in it, I found mentors outside of our field also. And so, global oncology, HIV malignancies, these weren't really things that radiation oncologists were necessarily as engaged in as they are now. And I think it's a really great way to start a new pathway if you're interested in doing something like that. That's great. Ashleigh, you mentioned something about that I thought was interesting about aligning healthcare incentives with our goals for patient care. Can you and all of you, feel free to chime in, talk a little bit more about how on the clinical side we can do that to make sure we are collecting the information we need, addressing the challenges patients face outside of our clinic, and really moving the needle on social determinants of health?
So I actually I'll answer the question. I was more referring big picture to basically healthcare incentives in general. And that's really kind of an economic, sort of financial. If you think about what decision makers high up in an organization who are keeping track of productivity, the incentive structure doesn't tell you anything that points to, we're all incentivized to give good patient care. I think that the incentives towards equitable care that addresses, the social determinants of health in a way that makes the individuals who come to care and get good outcomes, it makes it equitable. I think that the incentives aren't aligned towards that, right? I mean, I think there is some innovative work going on in the payer space. Certainly with CMS, I think that they're very interested in aligning incentives that are not directed at quantity and revenue generation based on the amount of care given. I mean, healthcare is very medicalized in this country, and I think there's a recognition that may need to change somewhere in the system. I think so. Practically, I think about this a little bit. I mean, I'm a little past mid-career, and I think if you sit on a committee, or if you are serving in an operational administrative role where you're talking about productivity metrics, like where is there space in how you design and faculty incentives to make sure that that care addresses health equity. I mean, that's complicated, and there has to be some real dedication on the part of leadership, I think, within institutions. I think maybe even simple stuff, if you're not in those roles and you're more junior, when you're in clinic and people are talking about patients, as Monica mentioned earlier, how do you describe a patient, or if there's a conversation about, we don't know how this patient got, this tumor got this big, or if you're maybe it's a difficult patient or a challenging patient, making sure that the language around all of that is grounded in equity and not in judgment about things that you don't understand. And they're all things that we don't understand. So there's sort of this sort of local day-to-day things, this kind of, make the world a better, more equitable place. And I think as we percolate up through the system, then we all will take on roles, right? We'll all be asked to serve on committees, and we'll be asked to serve in decision-making roles about incentives and about productivity and about motivating ourselves to, so the department can meet its budget numbers. And what's going into that? Is it just about quantity? What's the payer mix? Is there room for a more diverse payer mix? And those decisions go on very high up, and individually we may not have control over that, but I think it's good to understand how those decisions influence actually even who comes through the door, or when they come through the door, whether they come through the ER, or whether they come, through the front desk. And so I think, being aware and to the in the places where you can push the needle, I think, and then also just being aware policy-wise that these big picture decisions about how healthcare is financed are driving these inequities in many ways.
To Ashleigh's point, I mean, we do now have Z codes that do cover many of what we've been talking about. The caveat is, I think where physicians in particular get frustrated is, I can list it. It's hard to list something I can't intervene on. And so I think Ashleigh's point around a large advocacy pool, that sometimes it's really about the regulations. Well, why can't I use money for healthcare, for housing? Why can't I use money for healthcare, for transportation, right? We see some of these demonstrations where we're starting to understand that moving the money across sort of what is usually a firewall, you can't use money to do X, is really important to really address some of these. So we as physicians really have to use our advocacy as a group to help advocate on behalf of our patients, because it is our job if we want to do exactly what Ashleigh says and provide equitable care.
So I echo everything that Monica and Ashleigh have said. And I also wanted to point out that some of the electronic medical records like Epic currently have social determinants of health, variables that you can actually collect in your clinic. And so it's stuff like transportation, food insecurity, housing, finances. So I think there is a culture shift where we're more interested in how people's living and working conditions affect the type of how they interact with the health system. But I think the key word here is organizational culture change is what needs to happen, where individuals we find a way to balance our goals of, maintaining a profitable enterprise, but at the same time delivering care to patients in ways that take into consideration where they're coming from and what they have available to them. And that's going to be very difficult. And I think the type of work that we all do hopefully will help inform the main stakeholders and decision makers about how they can improve how we deliver healthcare to all our patients.
Yeah, those are great points. And I think it's, it's challenging. We have in radiation oncology probably some of the longest consult times that we spend with patients where, we're going through the history in a detailed way, exam, talking about trials, treatment options. And even in, an hour for a new patient visit, it's a lot to cover. And at the same time, we could have the most absolutely best cutting edge treatment study, intervention. And if the patient doesn't get it because they don't have transportation, or they have financial toxicity, or they have other things preventing them from getting the treatment, then you have to ask yourself, what have we really done? Have we helped this patient? So those are really, really great thoughts. What would you say where do we go from here? What are the next big concepts or ideas in social determinants of health, either from a research standpoint, like thinking about frameworks and kind of pulling these concepts together, or more on the advocacy and policy side as well?
So for me, I really think this whole social genomics and epigenomics is actually going to be very informative. I think, I don't want to say detractors, but I think individuals who don't quite understand social determinants of health, this provides a new language and a new viewpoint for them to really understand that, these socio-environmental factors do have implications on people at a molecular level, and that has significant implications for their outcomes. So I think that field has developed over the past 10 to 20 years, and I think it's going to be really transformative in terms of helping us understand that, hey, where you live and where you work actually really matters for your health.
I think related to that, this is a little bit my research hat. I think that in thinking about interventions, in genomics, there's this vast army of people who do amazing computational biology work. And I think it would be, I know that there are people who are doing this, but I think, having more cross-disciplinary computational sort of expertise to use some of these probabilistic and Bayesian modeling to think about interventions and sort of, because interventions in the past, it's very difficult to design, let's say, a patient navigation study, right? That's randomized trial and come up with a frequented stat that's going to be informative, because is it really ethical to randomize a very needy population to a pamphlet or a person who's going to help them? That's actually very difficult. And then, it gets very hard to actually execute that. And the people who do these trials are actually usually very dedicated, caring, passionate people. And they're not going to say, no, I'm not going to answer your question because you were given a pamphlet. And so it gets very hard to do these studies and interventions and show that they work. So I think that actually some of the innovative statistical designs, transferring some of what's been done in genomics and some of these other studies and using it and applying it to some of these health equity studies and interventions, I think is an interesting sort of future direction.
I think the prior two speakers have elucidated this idea that diverse research teams, right? So let's put our equity hat on. Even in the research itself, right? Bringing expertise from the social sciences, bringing expertise from other fields to bear on this complicated problem complex problem actually, is really key to coming up with sustainable solutions.
Yeah, absolutely. Okay, well, we're getting close to the top of the hour. I've learned so much from all of you. Your work is really powerful. It's really inspiring. And hopefully we've given our audience members some food for thought as they think about social determinants of health, both in their own clinics, but also as an area of research and advocacy. I want to thank everyone for attending this session, and I have a couple of comments before we close. So first of all, the next DEIinRO session will be a Women in Leadership Town Hall. That is going to be on Wednesday, July 28th from 6 to 7 p.m. Eastern Time. No registration is required, and you can find more information about the upcoming sessions in this series at astro.org/DEIinRO. So at the start of the session, I mentioned the new ex officio council of ASTRO that's focused on diversity, equity, inclusion, and belonging. This fall, the ASTRO membership will vote on making this new council into an official and permanent part of ASTRO through a bylaws revision, which will ensure ASTRO board membership for the council leaders and also create a greater range and impact of DEI initiatives that's possible for us in radiation oncology. So please, please, please ensure that you're a member in good standing of ASTRO so that when the time comes this fall, you're able to vote to make the ex officio council a full council, because we'll need all of your help to do that this fall. So please check your membership status, be sure to vote, encourage other members of your teams, your institutions, your communities to vote for the HEDI Council. And thank you so much for attending today.